Okay, so now let's talk about malrotation. Malrotation, it's an anomaly of midgut rotation during fetal development, which leads to improper positioning of bowel, small bowel clumped towards the right side. This is the right side, so small bowel is clumped here, and formation of the fibrous band, lad band. Formation of the fibrous band, lad band. This can lead to volvulus duodenal obstruction. This can either lead to volvulus formation or duodenal obstruction. So, malrotation. You have the midgut rotation, which is improper, which leads to the abnormal midgut rotation during the fetal. And you remember that it was occurring in probably 6 to some weeks, right? 6 weeks and 7 weeks. The midgut rotates around the SMA and all that. So whether you had the anomaly of this in the development time, which leads to formation of this improper positioning of bowel. What you got to remember is this thing right here. You have the small bowel on the right side. You have the lad bands attaching from the liver towards the colon, or ascending colon, or maybe some sort of transverse. But this is something that we have to look for in order to diagnose malrotation. And this can lead to complication-wise volvulus and the duodenal obstruction. I think we have the volvulus thing next page, possibly. Yeah, so we're not going to talk about it here. Okay, now let's talk about intussusception. Intussusception. What do we have here? So here is the telescoping of the proximal bowel into the distal segment. Most commonly at the ileocecal junction, typically seen in infants and rare in adults. Usually idiopathic in children, less frequently due to unidentifiable lead point. Again, less frequently. Most likely it is idiopathic, but less frequently due to identifiable leading point or lead point. Idiopathic form is associated with recent viral infection like adenovirus, rotavirus vaccine. What are these doing? They are causing Peyer's patches hypertrophy, which is acting as a lead point. So you need something. The gut needs something so it can hang on to it and pulls, while it's doing the motility, pulls itself into each other. But you need some point where it's gonna hang on to that thing, right? So one of the things is like Peyer's patches hypertrophy. Peyer's patches hypertrophied because of the viral infections or the vaccine, rotavirus vaccine. Common lead points are, in children you have the Meckel's diverticulum, small bowel wall hematoma like IgA vasculitis. Adults, you have the intraluminal mass or tumor. So you have a tumor here. Intestines, they're gonna hold on to it, and while they're doing contractions, there's a telescoping of the proximal into the distal due to mass or any tumor. Causes small bowel obstruction. Yeah, you're basically obstructing the small bowel, and vascular compromise, right? Which leads to intermittent abdominal pain, vomiting, bloody, current jelly stools. Very important. Current jelly stools. Okay. And this, why are you saying this is intermittent abdominal pain or most likely post-prandial abdominal pain? Post-prandial abdominal pains. Because as the food gets down in your stomach, there's going to be start of the peristalsis in the intestine. So those peristalsis, they need more oxygen, right? So when they need the oxygen and there is not enough oxygen to supply them, this leads to angina of the gut. What is the angina? Angina means pain. What pain? Postprandial abdominal pain of the gut. Postprandial, after you eat the meal. Okay, it's like angina meaning abdomen is exerting, and as soon as they are exerting, they're having the pain. Okay. So here, where were we? The current jelly stools. On physical examination, you're gonna have a sausage-shaped mass in the right abdomen. Patients may draw their legs to chest to ease the pain. Okay, so sausage, very important. It's a sausage-shaped mass on palpation. Okay, and on imaging, on ultrasound, CT shows target sign. Look at this picture here. You have the target sign. Like, look, it's like a target sign, right? So I think, yeah, that's pretty much it for this one. Let's also talk about the next topic, which is volvulus. Well, volvulus is the twisting of portion of the bowel around its own mesentery or around its mesentery. Can lead to obstruction and infections. Can occur throughout the GI tract. So if you look in this picture, there's a twisting, like there's a twisting of bowel around its mesentery. That bowel, look, is all red. There you can see obstruction and also sort of infarction. And this can occur throughout GI tract. Gastric volvulus more common. So now they're talking about that it's throughout GI tract. Now they're talking about gastric. If you have a gastric volvulus, it's more common in the anatomic abnormalities, for example, in paraesophageal hernia, and presents with severe abdominal pain, dry heaving, and inability to pass the NG tube. If you have a gastric volvulus, your stomach has twisted around, like let's say it went up into the diaphragm, it twisted around or something in paraesophageal hernia. So now you cannot pass a NG tube because you can't cross this thing. It's twisted. And you're also going to have severe abdominal pain, dry heaving, and inability to pass NG tube. That's only with the gastric volvulus. Let's talk about midgut volvulus. More common in infants and children, minors, midgut for minors. Sigmoid volvulus, coffee bean sign on the X-ray, more common in older adults. So look at the coffee bean sign here. Look at this coffee bean sign. Yeah, coffee bean sign. So midgut, minors, sigmoid, and seniors. And this sigmoid is going to give you coffee bean. Okay. And midgut is going to be, although this had minors, one more thing is going to be you are going around that volvulus is going to be around that gut, mid gut. It has twisted around your SMA. Remember, the mid gut is supplied by SMA. So SMA is the main thing for it. Yep, that's pretty much what we have for this volvulus. Let's talk about other intestinal disorders. So what do we have? We have acute mesenteric ischemia. It's a critical blockage of intestinal blood flow, often embolic of SMA, embolic occlusion of SMA, which leads to small bowel necrosis. Picture A. Small bowel necrosis. This area is necrosed. Okay. Abdominal pain out of proportion to the physical examination. Very important. May see, again, red currant jelly. So you see red currant jelly in this, and also see in the intussusception. We just talked about it. Intussusception. Okay. Risk factors are AFib, peripheral arterial diseases, recent MI, and CHF. So the whole story in acute mesenteric ischemia is basically you are blocking the intestinal blood flow. Okay, that leads to small bowel necrosis. So when you have a small bowel necrosis, you have pain out of proportion, and you have a currant jelly stools. The risk factors are off to cause the block, right? So AFib can make a thrombus and can lodge into the some small bowel artery like SMA. All of them, some sort of getting into the block, leading to blockade or decrease in the blood flow. Those are all the risk factors. Then you have this angiodysplasia. Angiodysplasia is a tortuous dilation of the vessels, which lead to hematochezia. Okay, most often found in the right-sided colon. Very important, right? So right-sided colon, this is going to be angiodysplasia. More common in older patients, confirmed by angiography, associated with end-stage renal disease, von Willebrand disease, aortic stenosis. So you have the thing here is hematochezia coming from the right side. Very important. What if you have the hematochezia coming from the left side? That's diverticulosis. We did that yesterday. Diverticulosis. Okay. So this was acute. Let's talk about chronic mesenteric ischemia. You have intestinal angina, atherosclerosis of the celiac, SMA, most commonly affected are IMA. All three. So basically you're looking at atherosclerosis of any of them, which leads to intestinal hypoperfusion, which causes postprandial epigastric pain. And I talked about how you would have a postprandial epigastric pain, which leads to food aversion and weight loss. So you don't want to eat any food if you have pain. I mean, you get the point there. And that's only with the chronic. Why chronic? Look at acute. If you have acute mesenteric ischemia, I mean, right away there's a necrosis of your small bowel. You have necrosis, you have extreme pain, right? You have because of the necrosis. But in the chronic, you have pain as you eat. You have pain as you eat. Why? Because in that pain, in that time, you need more oxygen, which you cannot give because the arteries are atherosclerosed. So you have pain when you eat, angina of intestine. But over there, you have a full block. You don't get the blood. So that's the difference. Let's talk about colonic ischemia. Colonic ischemia. Now, crampy abdominal pain followed by hematochezia commonly occurs at the watershed areas. What are the colon? In colon, what are the watershed areas? Or in all GI, you just have two watershed areas. One is the splenic junction or splenic fissure, and secondly, the rectosigmoid junction. Well, right here, actually. Typically affects the older adults. Thumbprint sign and imaging due to mucosal edema or hemorrhage. Okay, that's the colonic ischemia. Okay, occurs at the watershed. And why would you have that watershed? For example, we talked about how if you have hypotension, you can cause this. Shock, decreased blood flow to your GI structures, you can cause this. Okay. Ileus. Ileus is intestinal hypomobility without obstruction. You just have ileus. Ileus meaning you just have hypermobility without any obstruction, which would cause constipation and decrease flatus. Distended tympanic abdomen. So when you have constipation, decrease in flatulence, then leads to your distension of the abdomen or tympanic abdomen. You hit on it, there's gonna be sound coming off it. And when you look at the bowel sounds, they're decreased because of constipation, because of hypermobility. Associated with abdominal surgeries, that ileus occurred because of abdominal surgeries, opiates, hypokalemia, sepsis. No transition zone on imaging. No transition zone on imaging. Okay. And you have a treatment as bowel rest, electrolyte correction, cholinergic drugs. Again, bowel rest, electrolyte corrections, and cholinergic drugs to stimulate. Why are you giving this? To stimulate intestinal motility. And you have no transition zone. As compared to this, where I think we did talk about it here as well, that there is going to be a transition zone. Transition zone. Okay, I mean, if it comes up in my mind, I'll definitely tell. But here we have no transition zone. Okay. Alright, moving on to the necrotizing enterocolitis. It is seen in premature necrotizing enterocolitis, seen in premature formula-fed infants with immature immune system. Necrosis of intestinal mucosa, commonly termed in ileum and the proximal colon, which leads to nematosis intestinalis. Arrows in B. Look at these things. Nematosis intestinalis. And also you have the pneumoperitoneum and the portal venous gas. Okay. So basically what's happening here is, in this thing, you have hemorrhage, necrosis of bowel wall, which leads to bloody stools, one thing. Second thing is when you have A formula-fed infant. Let me change color. Formula-fed infant. This leads to bacterial invasion, which caused ischemia, hemorrhage, necrosis of the ball wall. So when you have that, the air goes out, causes nematosis intestinalis, pneumoperitoneum, and portal venous gas. Okay. Association is always with this thing, which is the formula-fed infant, child, premature, or formula-fed infant, which has a immune. Why we are saying premature? Because of immature immune system. So other signs, symptoms are you will have abdominal distension because of all that gas. Bowel obstruction can also occur, secondary to fibrosis, as the inflammation is subsiding. Okay, so that's pretty much all for the necrotizing enterocolitis. This thing, nematosis intestinalis, looking at the picture. Let's look at a picture here. So you can see that the air is in the bowel wall. That means the air is in bowel wall. Look, it's in the. I mean, I don't know. Maybe you can't really see, but the air is within the bowel wall. So air goes into the bowel wall, goes into the peritoneum, and also portal venous gas is there. Okay, let's talk about proctitis. That's the inflammation of the rectal mucosa, usually associated with the infection of gonorrhea, chlamydia, Campylobacter, Shigella, Salmonella, HSV, CMV, IBD, and radiation. Patients report tenesmus, rectal bleeding, rectal pain, and proctoscopy reveals inflamed rectal mucosa, ulcers, vesicles in the case of HSV. Rectal swabs are used to detect other infection etiologies. Okay. Inflammation, proctitis, inflammation of the rectal mucosa, associations with all of these things. It presents with tenesmus, rectal bleeding, rectal pain, because it's inflammation of rectal mucosa. So for sure you can have a rectal bleeding, rectal pain, tenesmus. And when you do just the proctoscopy, you will have the inflamed rectal mucosa. And if you were to do some rectal swabs, you are gonna detect if there is an infectious etiology in all of this, right? Okay, let's talk about some extra. What do we next? What do we have here? Let's talk about small bowel obstruction. Wait, where is this? Small bowel obstruction. Normal flow of the intraluminal contents is interrupted. Yeah, I mean, with the name small bowel has been obstructed. Sure. Normal flow of the intraluminal contents is interrupted. Great. Which leads to fluid accumulation and intestinal dilation, for sure. Proximal to the blockage, I mean, same thing. Proximal to blockage, you have all the fluid material coming in, okay? And intestinal decompression. So, again, same thing. Because you have the obstruction, let's say here, distal to it is just compressed, collapsed, decompressed. Where was it? present with a decompression of the distal tube of the blockade. Okay. Presents with abrupt onset of abdominal pain, nausea, vomiting, abdominal distension, compromised blood flow due to excessive dilation or strangulation, may lead to ischemia, necrosis, perforation, most commonly caused by intraperitoneal adhesion, fibrous band of the scar tissue, tumors, hernias in rare case, meconium plug in newborns, which leads to meconium ileus. Upright abdominal X-ray shows air fluid levels. And looking at picture C, you can see the air fluid levels. Look, air fluid levels in the upright images. Okay, management is the gastrointestinal decompression, volume resuscitation, and bowel rest. So this was pretty simple, that you have the obstruction, small bowel obstruction. The important thing here is how it's going to present. It's going to present with abrupt onset of abdominal pain, nausea, vomiting, abdominal distension. So you have pain and the stomach is getting distended. And when you were to check on, let's say, an upright X-ray, you will look at the air fluid levels. Very important, air fluid levels. Okay, so the proximal is going to be dilated, distal is just decompressed intestine. Or let's talk about the last thing here. What do we have? Small intestinal bacterial overgrowth. In the small intestine, the bacteria has overgrown. So let's read. Abnormal bacterial overgrowth in the small intestine, normally low bacterial colony counts. Risk factors are altered pH, achlorhydria, the PPI use. Anatomically, you have a small bowel obstruction, adhesion, fistula, gastric bypass surgery, blind loop, dysmotility, gastroparesis. Immune-mediated IgA deficiency, HIV, presents with. Now, if you have an overgrowth, you are going to present with bloating, flatulence, abdominal pain, chronic watery diarrhea, malabsorptions, in which you were looking at vitamin B12 in severe cases. Diagnosis are carbohydrate breath test or small bowel culture. Small bowel culture. When you do a small bowel culture, you can see, oh wow, there's so much growth. And the growth, why did they grow? Question is, why did they grow, right? They grow because of all of these factors. Altered pH and all that, PPI and all of them. Or either one of them, right? So these are the factors that lead to the overgrowth. When the bacteria have been overgrown, they're like, who's the boss now? They are going to cause their things: bloating, flatulence, abdominal pain, chronic watery diarrhea, malabsorption of the fats, vitamin B12 in severe cases. And you can diagnose them by checking out the cultures. Okay.